we've got a couple of questions for you. We have one question around, this is really interesting, about the trigger of lymphedema in men. Are there any different triggers for men than women? So we have in the comments, somebody's put that they thought it was largely due to trauma, like infection, DVT, organ failure, those sort of things, and cancer treatment. But are there any predisposing factors in men that can make them more prone to developing lymphedema?
Oh, okay. This is an interesting one. I would say there's no particular research that says there's a difference in terms of gender between men and women as the triggers. I think it's more a case of going, actually, in certain areas, there might be a higher prevalence amongst a certain group. So an example is, as we said before, sometimes men are more at greater risk of, say, cardiovascular disease, as an example. So some of the things might be that we've got some diabetes, different conditions that come to play, let alone the notion about substance misuse, which sometimes is a bit higher in men. So it might be more drug, intravenous type things. So suddenly that might be the triggers for a certain group. But it's about looking at them as individual groups rather than as men as a whole. There isn't necessarily a difference. I think it's the different factors that come to play that might put men or women at greater risk because of different causes. It's a bit like because of the Chris Hoy effect in terms of promoting about, unfortunately, his prostate cancer diagnosis. And we know cancer, etc., and prostate can lead to lymphedema, but suddenly prostate cancer has become now the more common diagnosis in the UK. But that took somebody coming forward to raise the profile, to say, actually, have a conversation, ask for things. But what was great about that was the notion that Chris Hoy, as an example, said, actually, this is my story. This is what you can do to help yourself to go forward. And with that, that's brilliant. But as I say, there isn't necessarily a difference. It just might be different factors.
Thank you so much. And a question for you, Matt.
Yes.
Can you tell us a little bit more about when you were told in that awfully blunt, non-compassionate way that this was your diagnosis, and you were just told to collect some garments on the way out? What happened after that for you? Did you then go and see your GP afterwards? How did you get referred to a lymphedema service, if indeed you did? And what was your first experience of compression like?
Okay, so I'll answer the first part about the GP, because that was the obvious place to start. And unfortunately, my GP didn't really understand much about lymphedema and didn't really know where to point me to find help. So thanks to my wife, she went online and started searching. And after about 2 or 3 days of emails, conversations and searching, we think she spoke to a Scottish lady, which could have been Margaret Snedden from the BLS, who eventually said, there's a clinic in Kent, which transpired to be about 10 minutes drive away from my house. When I spoke to the GP about this, he said, oh, right, okay, I thought that was just cancer related. So there is this dividing line, as we know, with patients that have cancer, they get the priority treatment with certain lymphedema services. But once I'd found the clinic and I booked an appointment with the amazing Kelly Nixon, I adore her. I would not be sitting here doing this interview had it not been for Kelly. And she at the Hospice in the Wheel took me under her wing, listened to me moaning for 2 hours, and then gave me the toolkit, the explanation, the confidence to go away and manage. And I think that's important and I've seen a comment flash up on the screen about services disbanding. We aim, if possible, as I'm sure the healthcare professionals do, to maintain that relationship as long as possible and see you time and time again so they get a feel for how your limb is performing. And we then open up a bit more, to somebody that we're building a relationship with. And that's also important. So having opened up to Kelly, I considered her then my confidant, my friend. So if anything was bothering me at the time, I'd save it for my 6-month appointment, which isn't always healthy, let me tell you, and then offload at my 6-monthly appointment with my clinician. Thankfully now, I think, you know, the awareness of lymphedema is far greater than it was 14 years ago. Having said that, there are still some GPs out there, I understand, who could do with a bit of training or understanding of what lymphedema is and where the nearest clinics are available to point or signpost people to.
Thank you, Matt. Thank you there. We've had a question about whether males or females are the greater affected group. And Gary, I think you covered that largely in the presentation by saying that we know of far less men with lymphedema, but it's not an actual fact that that's the numbers, because this is only what's known. And we've covered a little bit around the difficulties of people presenting with that. But a really important question has come in, which I want to discuss, because this is from Andrew saying, how should we talk to men about genital edema, given the concept around masculinity and around some of the sensitivities that you've discussed? And I think this is such a key thing to touch on in a presentation with both of you on the call.
Yeah, no. Matt, would you like to go first, or would you like me?
No, I'm happy to. I'm happy to address this head on.
Okay.
Because so in June, we're Father's Day in a minute, aren't we? So,
yeah.
So I presented with cellulitis in Father's Day weekend in 2011. So I'm about to celebrate my lymphaversary. The reason I say that is, at that time, it was such a shock to me and my family. We were focusing on the affected limb, and at that time, there was so much information that we were finding about lymphedema. It was a bit overwhelming. When it comes to scrotal, when it comes to mons pubis, it's never an area us fellas really want to talk about, right? Mm-hmm. So having worked with clinicians in this sector now for a good nearly 10 years, I decided to tackle this head on with my therapist at St. George's a couple of months ago. I said, look, I'm always explaining to my friends, my members, my followers, whatever, get it checked. And I haven't done it myself. So I did. I led by example, and I spoke to Anchor and said, look, this is an awkward one, but I'm not sure whether I have swelling in that area. And it's an uncomfortable conversation to have. Would you mind checking? Now, that was me volunteering. What I would urge healthcare professionals to do when they've built that relationship with their patient, they've seen them maybe 3 times, is perhaps just offer that conversation, offer that inspection, and it can be dressed up or framed as Gary mentioned in, look, we understand in some cases of lower limb lymphedema, it can spread. So now we've seen you for a few times. How would you feel about me just checking whether that, or have you noticed that it spread yourself, or can I inspect just so that we can proactively keep a control on the swelling rather than it getting out of hand? So look, I've done it. It wasn't the easiest conversation, especially with somebody I've known for quite some time, but that's where the trust comes in, and they are professional, because they've called professionals for a reason. So entrust them, because ultimately they're looking after you.
Gary, do you have anything that you'd like to add?
Yes, actually, because I think it's great, Matt, that you've spoken about that, especially about your own experience of tackling a conversation that's uncomfortable and also expressing another form of vulnerability about the leg, now suddenly vulnerability about this, but the notion of I need that looked at because I want to ensure that I remain healthy going forward. And I think it's that angling of always having an opening conversation that comes to play in terms of forming a part of it, in terms of, like, as you say, the leg itself can be swollen, but we also need to make you aware that your genitals, and again, it might be the terminology, you might notice that your penis, your dick, your scrotum, your balls may be more swollen. It's about using their terminology as well, that they understand. We're healthcare professionals, but we also have to term the terminology around it. Equally so, men may also use humour as a deflection or as an insight to what's going on here. I remember one gentleman I went to see, it was palliative. but he ended up having a scrotum the size of a watermelon, unfortunately. And because of this, I always remember, because he said to me, he said, if I was anything else at any other point in my life, I want to be a porn star at this moment in time with everything that was going on. And so we chuckled about it because that was the intention. And then after that, when we settled, I went, well, actually, how does it affect you? And then he opened up completely. It was that humor, which was trying to deflect, but also trying to deflate what is a very awkward situation to bring you down. And I always recognize that in my male patients. And sometimes humor is also the way to get in to things, and it's not being unprofessional. And then we can start to tackle things. But then tackling it is also about going, actually, you know what we need to bring in is other things that's going to really help you. What is it you like to wear? You know, I joke with them going, actually, your boxers need to go out now. Bring in your briefs. And we have a bit of a chuckle going. It's probably the briefs that your grandparents initially wore, but you know what? They've got better over the years. You can get better ones. It might be that they don't want our compression shorts, but they will wear, say, cycling shorts or something else, and then eventually build themselves up to what we're thinking might help support them even more. It's always about starting where they are, but recognizing the communications that might be different between the genders, where humor may not work in one group, it may work extremely well here. And I think it's about that notion of building that rapport, but always being open and saying, actually, even on the first consultation, which I usually do with people, going, actually, I'm going to look at your leg, but also, just in case, there might be something that may go on over here. I won't look at it now unless you're telling me it's a problem. But always remember, I'm going to bring it up at every assessment, just in case. So it's always there. But
that's brilliant advice, because that's such an easy thing to say when you've got somebody that you're examining. It's so easy to say, you know, this can happen. You know, so you're sowing the seed to make people think, you know, I know about this and this is perfectly reasonable. This is something we deal with. We're not scared of it. We're not frightened of it. And sowing that seed of saying, you know, I'm not going to strip you off now, but actually I will keep asking you about it. I'll keep, you know, making sure that you know that this can happen, unless you are going to say to me that this is a problem now. And then, of course, that conversation may be more natural from that point. That's such a great thing. And also that language, yet again, we've talked about terminology and language a lot here. And I found previously, having been a lymphedema nurse for many years, that actually using the word genital edema is not that handy. People don't know what I mean by that. It's a very medicalized term that people haven't understood. And as you said, using layman's terms, something that people are comfortable with, that people understand as everyday language, that's been really helpful. But not, as one of my colleagues found out, she used the term groin a lot. And so people think of your groin as being the top of your leg, but nothing else. And she learned that the hard way. But certainly you've hit on some real top tips there. And there's some real empathy coming out in the chat around the fact that lymphedema itself is such a daunting word for both patients and clinicians, that also it's about education and about preparation, which, Matt, you had neither of when you received your diagnosis. And somebody else sharing good best practice, saying that they start their consultations by asking patients what they want to achieve or gain from their appointment, because it's a journey together. And Matt, that's how you've described your journey, relationship and friendship now with your therapist, which is great, and your gratitude. One final thing, I'm aware that we're moving on with short time left now in this, what's been the most amazing webinar. But Matt, have you any experience of compression bandaging? Somebody's asking. Did you have, or have you ever had compression bandaging? And Gary, in your experience, is there any more compliance with men perhaps in this group? Do we think there's anything specific around bandaging men that would make them more keen to undergo this therapy? So over to you two. Matt, would you like to go first with your experience?
Absolutely. I think most healthcare professionals will understand that the first objective post-diagnosis is to reduce the swelling. So I had multi-layer bandaging for a 3-week period, twice a year. And if, you know, this is about me giving you my story. This will be different to other people who share theirs, but it would have tremendous results for the 3-week period, and I'd see a significant reduction. Just to give you an idea, probably 46% volume going down to about 28%, 30%. That was a massive motivator for me. However, after bandaging, when going back into the class 4S, 60 to 90 millimeters of mercury, I'd say the rebound would slowly start, and therefore a month later, I'd be back to square one. So we tried a 6-week back-to-back session of bandaging with the multi-layer. And after 4 weeks, I got folliculitis. It was very painful, and they abandoned the treatment. So yes, wraps I have at home are a good alternative to bandaging because I can control how often I wear them. If they need loosening or tightening, they're very easy to do. You know, there are many variants of wraps on the market. Most of them I think you can get on prescription. I'm sure Katie could share the range that Sigvaris have. There's also other products on the market that, again, you know, you can find on our website if you're interested for wraps. But yes, I've used them. Yes, they've worked for me, but the multi-layer temporary, which is why the wraps, the Velcro wrap systems, for me personally, are a good solution.
Thanks, Matt. And Gary?
Okay, about compliance, and then I think it's always about the notion of going back to the beginning. What is their purpose in attending that particular session? So I think it's going back to that. Are both purposes, the clinician and the patient, or the man in this instance, the same? And if it is the same, then we can go forward with it. And with this side of things, it's about the notion of also saying it's investment. And it might be using those terms. You're investing in yourself to achieve this. And also it might be telling it as it is. Look, it's going to be bulky. It's going to be a bit difficult at the beginning. But also remember, you know, if we're doing this every day, investing in you investing in yourself, we're going to shift so much fluid perhaps in that first week. And also, some men may want the evidence behind it in terms of say, actually, you know what, I'm not quite ready for it. But actually, if you give me an article, I can go away and read about it. It's about tailoring it because, of course, sometimes they talk about the general population only having an illiteracy age, sometimes 7 to a 10-year-old. And so equally so, some people may be highly educated or not quite have the education, but have a great understanding around things. It's always about tailoring it. But I also think it's about the terminology. You're investing in yourself to achieve this purpose. It's going to be like this. And here's some of the evidence. And that might be enough to get them a bit more compliant to where you are. But we also have to understand the reasons why they're not compliant. Their reasons, their faults. But that's just my thoughts around it over the years.
I think that's absolutely brilliant. Thank you. And such a difficult kind of concept and question because it's down to personalisation and individualisation. But that was brilliant. Thank you. Somebody, Fiona had put in the chat, Matt, that Lymph United didn't appear to target primarily men. And Katie's popped in the chat there to say that everyone's welcome at Lymph United. It's for one and all. That's correct, isn't it?
It really is. And I suppose the page I would point you to is the Meet the Members page, where we have more men than I care to imagine sharing their stories, and 2 more are joining us within the next few weeks. So yeah, that kind of creates its own friendship group.
Fantastic. Well, we've come to the end of this amazing webinar. I hope it's been useful. I cannot thank Dr. Gary Cooper and Matt Hazeldine enough. Katie, thank you so much for bringing this together. There's so much that we can take away from this to help in clinical practice. Don't forget to continue to support Legs Matters Week this week. Become a friend member of the British Lymphology Society for free to get all of their resources. I've popped a few things in the chat for you that will support managing genital edema in men and women. Once again, to everyone involved, thank you very much. And thank you to you for being with us and listening. Bye-bye now.